On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
We're back for On the Scene video, and I'm Peter Block. On my far left is Tony DeMaria, and my immediate left, Deepak Bach. We're going to talk about the other late-breaking clinical trials on this second day of TCT. Tony, I'm going to throw the first to you, the POSEIDON trial. This is, again, renal failure, getting a little boring here. We've done this 10,000 times, so this is 10,001, but interesting trial, actually. Hydration, which seems to be tailored. Do you want to talk a little about that?
Yeah, well, the POSEIDON trial, again, looked at CNN contrast-induced nephropathy, which is actually an expanding problem as we do more and more radiographic procedures, not inconsequential problem, one that's been niggling in terms of trying to really get around it. And the thing that seemed to work best was volume, and in the POSEIDON trial, what they really tested was personalized volume based upon the left ventricular end diastolic pressure. And based upon that pressure, hydration was given, and in fact, perhaps not surprisingly, there was a significant reduction, about 10% absolute reduction in contrast-induced nephropathy. So perhaps a little bit more quantitative way to make sure that the patients are hydrated, but in the final analysis, the value of hydration in patients who are getting contrast studies.
You know, one of the interesting things about hydrating folks is that I think in order to do this, and this is not part of the study, you need to do it before the kidneys see any contrast. So if you're going to hydrate somebody, it's probably worthwhile doing it at the very front end before any contrast is introduced. So the kidneys see this big volume push, everything, the tubules are jazzed up and ready to go, and when the contrast comes through later on, they just say, oh, this is fine, and get rid of it rather than clog it up.
Oh, absolutely. The older data actually support that pre-hydration strategy, and I think this trial builds upon that. And you're right, you know, some of it is sort of older knowledge, but I think it's important what these investigators did, which is systematically measure the LVDP and then tailor the hydration strategy based on that number. And that's probably something that you've done in your practice for years. I know it is, as a matter of fact. But that practice of routine LVDP measurement has fallen by the wayside in many hospitals. A lot of interventionalists no longer routinely measure LVDP, and I know that to you probably sounds like bad practice. I happen to be a big believer in LVDP just to know how much contrast I might want to give to get some assessment of what their baseline is, perhaps before starting a complex intervention with a huge dye load. So I think the authors have done something important, which is reintroduce LVDP into our consciousness.
Sort of like going to Saks and having a personal shopper.
Exactly.
All right. So,
no, Peter, we've published papers where people have devices that go in the coronary sinus as a way to reduce contrast-induced nephropathy. This is a whole lot simpler, although we've recently seen a paper where they use post-ischemic conditioning, you know, peripheral effects of post-ischemic preconditioning, and that looks pretty promising as well.
well, we'll see what happens to those. Let's move on quickly to AIDA STEMI. AIDA STEMI is the IC apixaban versus IV. I'm going to throw this one to you, Deepak. We've had IV, intranasal, all kinds of apixaban. Can we finally put this one to rest?
Well, I don't know that anyone's tried intranasal. That might be next. I wish you hadn't suggested it. But at least as far as the intracoronary, intravenous, I think this does put the issue to rest. It had been an open question, an important one, about whether for STEMI patients undergoing primary PCI, intracoronary apixaban would be better than intravenous due to some local effect. Makes a lot of sense anecdotally. I've done that in the past, and I've seen thrombus dissolve. But the data show it makes no difference. And the AIDA investigators had presented that main result before, no difference in their primary clinical endpoint. Now they've looked at MR and also saw no difference.
Okay, Tony, any thoughts on this? We've been over this 1,000 times. This is an MRI, I guess, study to see about infarct size, a real stub study. Again, no difference. Any thoughts, Tony?
Yeah, it's really fascinating, Peter. Oftentimes we start with a surrogate endpoint, like MRI, and everyone says, well, all right, that's a surrogate endpoint. Does it really make any difference in outcomes? Here we had the outcomes.
That's right.
And they're going back to the surrogate. Enough said.
Yeah, okay. So maybe we can get rid of the ipsissimab. It's not a bad drug. I mean, you ought to use apixaban.
Absolutely.
That's not the issue.
High-risk STEMI. And you know, what I think the authors wondered about is even though their primary clinical endpoint was negative, for the endpoint of heart failure, that as a sole endpoint was positive in the main trial. So the thought was, is that a real finding or a spurious finding given a negative overall primary endpoint? And I think it shows it's probably a spurious finding.
Okay, so those are the hot topics for today. Come back tomorrow for more late-breaking clinical trials from TCT.